Everybody, I'm Dr. Shatabdi, Pediatric Cardiology Fellow from Kokilaben Dhirubhai Ambani Hospital, Mumbai. I'm going to present an unusual cause of left ventricular dysfunction in a child after repair of anomalous origin of left coronary artery from pulmonary artery. The evaluation of coronaries is very important in patients with congenital heart disease before any surgery, since missing the diagnosis may be catastrophic in the OT. We tend to rely on color Doppler signal, which may be to diagnose L-kappa, but it may be fallacious in the setting of pulmonary hypertension and LV failure. We report a case of 7-month-old girl diagnosed with large PDA with L-kappa, who underwent PDA closure with L-kappa repair, but to our surprise had new onset LV dysfunction after successful repair with unusual cause for the same. Moving over to case proper. Our case was a 7-month-old girl who came with complaints of inadequate weight gain, difficulty in feeding and breathing. She was diagnosed with large PDA outside and was referred to us for PDA closure. On examination, she was malnourished with weight of 4.5 kg, which was less than first centile as per WHO growth chart, and she was maintaining saturation of about 97 to 98%. On examination of cardiovascular system, she had cardiomegaly with loud and palpable P2 and a short systolic murmur at left upper parasternal border. Her X-ray showed cytosolitis levocardia in AP view with CTR of about 65%, cardiomegaly, right atrial enlargement, left atrial enlargement, dilated MPA with increased pulmonary vasculature. Her ECG showed heart rate of about 120 per minute in sinus rhythm with left axis deviation, left atrial enlargement, and biventricular hypertrophy. However, 2D echo at our center showed a large 5 mm PDA with bidirectional shunt with normal biventricular function with LVEF of 55% and severe PH. On assessment of the coronaries, we found the left main coronary artery was arising from the non-facing sinus of pulmonary artery, but color Doppler in the coronary sinus was normal, and we attributed it with severe PH. So moving over to course in the hospital, child underwent direct reimplantation of left coronary artery to aorta along with PDA closure. She had an unremarkable post-operative course. However, during pre-discharge echo, she was found to have moderate LV dysfunction with normal flows in the reimplanted coronary, as is evident here. She had moderate LV dysfunction with LVEF of about 30%, and there were multiple coronary collaterals arising from the coronary. Child was planned for cardiac catheterization to assess the cause for LV dysfunction and visualize the coronaries. CAT showed good flow in reimplanted LCA with normal RCA filling from aorta. There were multiple coronary cameral fistula from the RCA and left circumflex artery opening into the right ventricle. She also underwent a perfusion scan, which showed reversible ischemia involving infralateral and lateral free wall of the left ventricle, involving the left circumflex artery region mainly. She was planned to be managed conservatively and was discharged home. She was asked to follow up after 1 month. During her 1-month follow-up, she had no cardiac complaints. She was gaining adequate weight. 2D echo showed good flow in reimplanted coronary and RCA with coronary fistula which were seen but decreased in size. There was no residual PDA and there was improved LV function with LVEF of about 50%. So moving over to discussion, association of L-kappa with PDA is extremely rare. Isolated PDA closure can lead to catastrophe in OT if diagnosis of L-kappa is missed preoperatively. We were able to diagnose L-kappa correctly in this patient, but due to severe pH and elevated RV pressures, flow in coronary cameral fistula was not apparent. So to conclude, color Doppler signal in coronaries may not be reliable in patients with severe pH and LV dysfunction. Demonstration of origin of LCA from main pulmonary artery is the only reliable clue for diagnosis of L-kappa. Flow in coronary cameral fistula was dormant and coronary perfusion was maintained due to severe pH. Normalization of RV pressures post-PDA closure led to unmasking of these collaterals, causing coronary steal from LC and leading to LV dysfunction. Usually flows in these close spontaneously and does not need to be addressed unless they are the arterioluminal type. Thank you.
Thank you.